will talk about skin integrity and skin function and obviously dysfunction, considering what's the class, right? And morphology of the skin lesions. What's morphology, guys? You've been all in English class at this point. What's morphology? What? What? Study of shapes, or basically the language of the language of the skin lesion. Yeah, shapes. Basically, you're trying to distinguish what are the basic building blocks in the skin content. This is a link posted. It's Merck manual, and you can access it and see what they look like. And there are tons of images all over the internet. The problem with it is what? What's the problem with tons of images on internet? What? Accuracy. Yes, accuracy is not. It's not accurate. You don't know who. You don't know who posted it, who, how credible it is, and anyway. But something like Merck Manual is definitely credible source. And besides, if picture taken by amateur, and by amateur I mean even if it's an MD with all legit rights to carry his research and for his or her research, this is a good picture. However, it's not quality of to publish on internet, so you won't see what we need you to see. You won't learn from it. But so I tried to pick pictures from Merck mostly that are very representative of what it is. And you guys, again, coming back to our conversation, please learn this, the language. It will help you a lot afterward in future if you know your skin lesions, because what's part of the nursing, what you do as a nurse, well, what's part of, there are lots of part of nursing, but what you do, you communicate, right? You communicate over what? Mostly paper and what? Writing, and you calling your physician, or verbally or over the phone. So you are writing either written speech or oral speech. You do communicate in words. You cannot, some do, but there are really restrictions, and you cannot just take the picture and take it to physician, say, hey, patient looks like this, what we're going to do, or he developed it. So you need to know your language to describe correctly skin presentation. And not to be confusing, you need just to learn the basics, not to go to an internet source at the time. Oh, you just seen it. Oh, let me look on internet. Oh, this looks like picture. Oh, yeah, that's like the little round thingy, and just patient starts having it. So you can't do that. So know the names, and this will help you with the names. Please know this, and yes, it will be on the test, because I want you to know it forever and ever and ever. So papules, okay? It's an elevated lesion. It's less than 10 millimeters. You already talked about millimeters some in AMP, but please also, if you don't convert it easily from inches to centimeters, millimeters to metric, please try to learn it at your leisure time. And so how much is 10 millimeters, guys? What is it roughly in inches? What is it? Is it 10 inches, 5 inches? Half, less than a half, right? Less than half. So inch to millimeters, the inch will be 25-ish, 25.6, or 2.56 centimeters. So 2.5. So you need to know that. The millimeters in diameter. If we say in diameter, we don't mean it's always perfectly round. What we mean, the longest, right? Okay. Or you can even say like 4 by 8 lesion, oval lesion, or you can describe it. But we'll say, if you say 9 millimeter lesion, you don't even say it's oval or round. That means tiny, fairly round lesion. Okay, it's elevated papules. Okay, everyone knows what papule is, right? At this point, you guys know, right? You looked at home, you know this stuff, and I know for some of you it's boring, but I still will talk about it because this is important. The next one that comes here, macule. So macule is flat. Papule is what? Raised. Okay? And macule, you can see it, but you cannot feel it. It's non-palpable. But again, the magic number 10 is what? The size. Okay, 10 millimeters. Okay, you need to remember that 10 is that borderline, and after 10 it turns into something else. Name-wise, the origin, like the pathophysiology of it, can be the same, but the name changes. So, for instance, macule will turn into a patch. And patch is easy to remember. I mean, I don't think people wear jeans with patches nowadays, but like before even my time, it was, I guess, in fashion. They will put a patch, and also patch. It's a patch. It's more than 10 millimeters, but it's a patch. And this is like extreme case. I pick extreme cases so you would recognize it better. It make more memorable appearance, so you will remember this. So yeah, this is fairly dramatic presentation. But what is it? It's macules and patches. The small ones will be macule, and the bigger ones will be patches. And some places macules already like fused together, and then they are making a patch. So, okay, what's a plaque? After I talked about all this, I want you to guess. What's a plaque? It's bigger than 10 millimeters, guys. I mean, anybody's elbow is bigger, right? Even pediatric. Even a baby will have bigger than 10 millimeters. Like if you don't know who it is on the picture, but even if it's a baby, you still would say this is bigger than 10, right? Okay, it's bigger than 10. Is it raised or flat? Raised. So what is it? A papule? Papule is less than 10, but it's a raised lesion, and it turns into plaque because it's more than 10. Okay, so that's the language. You guys need to know that. And I'm like, sometimes some of the students said, like, you can't just tell us. You guys need to know that. It's like telling us what to do. Yes, it's telling you what to do. So, I mean, if it's bigger, it may not never turn, may appear like this. Yeah, plaque is raised, patch is flat, and papule is raised, macule is flat. Yeah, that's good. That's a GRE question. Yeah, so that's a good way to put it. Yeah, or I don't know, MCAT question. I don't know, but it's like association is the same. Yeah, so yeah, that's the relation you can say. But 10 millimeter again is the magic number. Okay, so after that we're coming to this guy who is vesicle. Okay. This is a vesicle. Vesicle is what? Vesicular. It's filled with, you remember, like vessels. Now we have air vessels, but mostly vessel is what? It's a boat, right? Boat floats, so boat can float in a solid, so it's filled with fluid, so that's how you remember vesicle filled with fluid. But again, it's small thing. It's again how small it is. It's less than 10. So 10 is your magic number. Thankfully, someone didn't sit down there and say, "Hey, let me decide, and I'll be picking different number for each type of skin lesion, and then we'll just confuse people more." But in this case, everything is 10. 10 is cutoff point to change and to emphasize that your lesion got bigger or was bigger. Okay? So vesicles, what they filled with fluid, but what kind of fluid? It's clear fluid. Okay. Bullae is bigger vesicle, and it's more than 10, and it's bigger thing, and it's more than 10, and fluid-filled blister. Okay. Bullae. And so it's something burned, and it's this is not like a, like from the blisters from the shoe, something else going on, and most likely it's a burn. So, and there's some crusting there, so it doesn't look really good. It doesn't look like it's really infectious because the fluid is clear, right? So what you don't do with these vesicles or bullae, don't pop because it's sterile and it has its own life. If you pop it, you will introduce bacteria and cause infection. You can write blister, but you can say bullae. And you can, say blister. I mean, the sign. Blister is colloquial, but this is like bullae. So, but you can say blister and vesicle blister. It's really won't be correct. But bullae, you can say blister because blister we imply it's bigger than 10. Okay. Pustule. And pustule is a vesicle filled with pus. Easy. It's filled with pus. It's not transparent. It's infectious. You usually won't have a bullae or blister filled with pus because pus would tend to rupture, and it's just not happen. So yes. Well, what was clear? The fluid. Yeah, then it's vesicle. But impetigo is a infectious, right? Origin. So, but yeah, if it's clear fluid, you don't know. Difference again between nursing and advanced nursing or medicine is what? We do not diagnose. If you say impetigo, it's you diagnosing. So you have to describe it as vesicles. Okay. So, so you give the name, but you don't diagnose impetigo, and it's kind of fine line. Some things you can really say. Diagnose kind of in your speech, but again, you can't put it on paper. You cannot really say the word impetigo officially. Like you can say to physician calling report, "Oh, patient came with impetigo. Has he been diagnosed?" "No, but I think it is." So, and it's putting you under the. Yeah. Say it again, Katie. It's not politically correct. It's just not your scope. It's not correct or incorrect. But I mean, if you are practicing in your official capacity as a nurse, you just cannot diagnose as a registered nurse. If you advanced practice nurse, of course you can. But and this capacity, you can. Or if you are giving someone a report, asking for a help and consult, in advanced practice or as an MD, you still, if you're asking for help, you just give the picture, not your opinion. Because if your opinion is so good, why are you asking for help, right? So, but anyway, yes. Pustule will be under 10, considered again just because it's filled with pus. But in pustule case, if it's a pus-filled blister, it's highly unlikely be more than 10. But and most of the time they are under 10. So pustule, it's to remember at this point, you need to remember it's a vesicle filled with pus. Yeah, if it won't be big, high level, like very low, very high laying lesion filled with pus just under the skin. So vesicle is always superficial, or pustule is superficial. Bigger accumulation of pus will be something bigger, like an abscess, subcutaneous abscess. So, urticaria is wheals or hives, and it's usually allergic reaction, and it's localized edema, hypersensitivity reaction, which allergic reaction basically. And you've probably seen this at some point in your life, something like this. It's patch. Yes, ma'am. This, well, what is this then? If it's raised and big, it's a patch. It's a patch, but you know that's urticaria, but because it's hive, the appearance, the patterns of the patches, and this comes back to my. Are you diagnosing or are you giving a picture? You probably still, not probably, you're still giving the picture because you are being more specific what it looks like. But again, you are not saying that this is like penicillin allergic reaction with this. But that's that's a, yeah. This is a plaque. I'm sorry, I said patch. This is a plaque. It's raised, and you'll see like the borders will be very distinct, like their elevation will be and there won't be huge elevation, but they will be some markings. This is not just flat. If it's usually flat, it has no acute, most of the time, etiology. If it's big and flat, it's usually something chronic, or it's like something benign. If it's raised, it's something acute, like hypersensitivity reaction. This is a plaque, but because of the pattern, there's numerous plaques, you can say that this is urticaria, or you can call it a plaque. The differentiation, why you're saying is urticaria, because it's localized edema and erythema. They're red and inflamed and edema. It's like it has edema, like in third space it has some fluid too, but it looks like the same. So it's red, elevated, looks bad. Basically. They all look bad, but it still will be like hypersensitivity reaction. Yes, sir. In what? Yeah, yeah. Itching is not the allergic reaction brings you the itching, right? So, but you're looking at the pattern and you're looking at the redness and edema. But the plaque is more generalized term, okay? And patch and plaque is more generalized term. When we're talking about macular and popular, try not to use it in the same sentence. Even you see in the good books, sometimes they would say macular popular rash. But if you think about it, how it can be macular and popular, it's probably not. It's a popular rash, but whoever was writing, they think that it also can be macular. It can be flat and raised at the same time. So pick the word and use it. But when you report it, and you'll hear it from many people, but it's not correct to use them in describing the same rash. And just some people would say that it's okay to do, but it's not okay because it's either one or the other, macular and papular. So, okay, so this is like the pattern, and the redness, erythema, some edema, and it's localized edema. It won't be like edema from heart failure. It will be some like raised redness and raised like puffiness. Yes, ma'am. Uh-huh. Right. But also your inflammation. Yeah, the cause, the cause like inflammation, it's a hypersensitivity reaction, and the histamine is involved for your inflammation. So yeah, this is all part of it. But for now, for this, you need just to know that it's urticaria. Okay, so this is the presentation. They can. No, itching comes because of the allergic reaction, but it can be without itching, so you don't know. But you're still looking at the pattern, and you're still looking at the redness. You can say, if you are not sure, call it what? Plaque. Numerous plaques with erythema. So you can say that. You don't have to say, go. And basically, again, it comes to what I was saying. If we say like, we start thinking diagnostic, is it hypersensitivity reaction, why it's happening? We don't need to know why it's happening when we're describing it. After we are describing and we want to know more, we can think why it's happening. But right now, you just say it's what? Patch or plaque, guys? Plaque, because it's elevated. Okay, so you go. Rash, again, rash is what? I just was saying that. It's general. No, it can be in one spot, one big spot. But what's rash? And I was using words macular, papular. You can say macular or papular rash. So it's a collection of macules or papules. It's not, or you even can say vesicular rash. But the main thing with rash, it's macules, papules, vesicles, small lesions. So, okay, scales, it's like icing on the cake, right? Scales, it's usually scale lays on something else, but if it's, it can be on just clear skin in theory, but it's usually there is some kind of plaque or patch. Scale, it's just scaly appearance, and that horny epithelium, so that the hardened cells will be collecting as scales. Why this happen? If we're going to patho part, it's a big, fast turnover of the cells. So they are, and I won't be testing you on that, guys, at this point, but if it's some kind of disease such as what, this is not really typical, but fungal, but what's the disease with the big turnover of the cells? Psoriasis. So, psoriasis, the cells rapidly divide, and it's not cancer, but they rapidly divide, and they can have scaly appearance, which is what? Psoriasis is a patch, right? Oh, I'm sorry, a plaque. So, a plaque. So you'll see, but the scaly appearance. So you can say scaly plaques. Okay. And fungal also infections, of course, have scaly appearance too. So scaly appearance. So it's all, dermatology is such, they always say, oh yeah, it's so easy to do. They just look at the skin and just give ointment, but it's really difficult because you have to distinguish between very benign condition and something that really can kill someone, and it's lots of different things. Yes, Sharon. No, it's just the turnover of the cells for some reason, or most of the time, but it's also like whatever disorder or organism we have kills it and leaves there like fungal and creates the scaly appearance. It's a dead cells on the surface. So it's already, they are like hardened cells. So, but psoriasis is rapid turnover of the cells, which causes that. Okay. Telangiectasia, you guys need to know this word. You've seen it many times. You probably didn't pay attention, but most people have it somewhere. What's the other like colloquial name for it? Small spider vein, little tiny spider vein, and it's really tiny vessels. So, and it's telangiectasia. Yes. No. You can have telangiectasia. Telangiectasia is permanent. It's there. You can, I don't know, but I'm sure there is some kind of treatment you can do. But rosacea is treatable inflammatory disease. There is no inflammation really here. This is just dilation of the vessel. But they permanently, it's like little tiny spider veins. And permanently dilated. So you can't take vasoconstrictor and they won't go away. Okay. Yeah, basically that's the only way. Like it's basically like varicose veins, but in very small. Yeah, varicose veins, big veins. Though, but this is very rough like comparison. But this is like spider veins, permanently dilated. They would be there. You can't take them out unless I don't know if you can surgically. You probably can, but imagine how to take all these little veins out. And sometimes it's on the face, sometimes it's on the legs and feet. So verruca is just warts. Okay. Warts. What's SK? You guys, if you read the book, SK. And SK is not fake cologne like Calvin Klein. They're trying to sell it like SK is seborrheic keratosis, right? You guys know that. No, it's not CK, it's SK, seborrheic keratosis. Okay. So basically it's a wart. Or if it's turning into bigger size and flat, you can say like verrucous lesion. Verrucous like warty appearance. So you can say what? Patch or plaque? It's raised. Plaque. You guys are good. Plaque. So you can say 2 centimeter plaque with verrucous appearance or with scaly appearance. It's like very creative field, dermatology. You have lots of things to use to describe the same thing. But the point is, whatever you use the correct ones. If you want to build your own vocabulary, eliminate the ones you don't like, do it, but try to describe all these terms you can. And I picked the ones, the most used ones, and it's really hard to eliminate them. Okay. What's this? Lichenification is just normal skin. It will thicken and the markings will go up, and that's it. And you really kind of, what happens? Misuse, something drops, wears off, and gets thicker and thicker, like, basically thick skin. So, skin mark. So, in duration is even deeper thickening of the skin. So, like callus, yeah, callus. But basically it's where you excessive use things, happening most of the time. So, but you guys, if you remember all this, I will be very happy. For like spring break, I'll be yay. It's be nice. And this is like umbilicated lesions. It has umbilicus, right? So it has depression inside and central indentation. Usually viral, but what also can be called umbilicated lesion, something with the depression inside, some kind of carcinoma, usually like basal cell. So xanthomas, it's yellowish waxy lesion. It can really be a good sign for what? Extra cholesterol. So you can't say like how much cholesterol the patient has, but most likely they have some kind of cholesterol disorder or something. So it's good to check if someone, and I'll show you it in a minute. So it's yellowish. It's hard to describe, but when you see it, and I'll show it in a minute, you'll know what I'm saying about. But yellowish, waxy, raised lesions. And technically what it will be, xanthoma, yeah, plaque. So if it's so you guys like know that difference. So again, please do yourself a favor, and me too. Learn this, because this will be on the test, and why you need to miss the easy question you just can memorize. This is easy question. You don't have to spend time on retrieving it from your thinking about it. You just know the answer or not. If you start if you didn't study all this up to this point, you'll be thinking, oh, which one is that? This is this one or that one. You'll be wasting time on easy question while you can use it on something like you can think about and analyze. But this is nothing to analyze. It's just memorizing the vocabulary. Okay. So let's talk about skin infection. That was the vocabulary, the language, morphology, skin infection, right? At this point, again, everything is targeted basically to primary acute hospital care, not primary outpatient care. So what you will see, superficial fungal infections, ringworms, athlete foot. Again, if it's scaly, right, dead cells, they are keratinized, they are hardened cell. And where fungus likes to live most of the time, guys? In which type of environment? What? No. Cool or moist, yeah. And you're saying, yeah, my skin is warm, but yeah, the skin is warm, but it's not warmer than internal temperature. So, and very few fungal infections will actually live on, humans, mammals, someone with warm skin, right? Most of them, they prefer to live on either dead material, decaying material, or plants. So that's good, because we don't have many of them. Okay. And unfortunately, there are a few that will thrive in warmer environment, and it's, as we talked many times here, Candida or Candidiasis, and sporotrichosis, another type of the fungal infection. But they all will, these two will go inside. That's the problem. Mucous membranes will be attacked. So, and for you just to know, again, from this course, just candidal infection, you need to know what causes it, fungal infection, and what it can show in the adult. And I won't be telling it again, because I said it probably 38 times. So impetigo, it's crusty lesions. Okay. And streptococcal hypersensitivity reaction can happen. So it's basically strep infection that causes this appearance, and it will go away with treatment. However, if it's not treated, it may cause glomerulonephritis, so you can damage kidneys, which we don't want. So basically very superficial definition, but it's treatable with antibiotics because it's streptococcal and can be easily treatable. This ones, I want you to guys remember this very well because you'll see it many times in the hospital, and I like my observationally just from clinical side, you see more and more for some reason of this. And so what happens, cellulitis and erysipelas is, and it's not syphilis, it's erysipelas. They are superficial bacterial infections of the skin. What's so distinct about them, it's superficial, it's not deep, it's not abscess, right? With superficial, what you having, it's they call demarcation or border, like demarcation line between which South and North what? Koreas? What's between South and North Korea? The border, you call it demarcation line, right? So the same is demarcation, and that's distinct border demarcation, and that's South and North Korea. It's easy to remember because same country, kinda, but it's divided, and he is the same. Same skin tissue, it's divided, and they completely opposite. And I won't be doing any more political parallels with it, but yes, sir.
So is that a description or a diagnosis?
It's a diagnosis. So, and you can say like erythematous patch, or it's not plaque, and it all depends how it presents. It can be raised, and you'll see the border plus some elevation. So the problem with is erysipelas is very, very marked, and cellulitis is more or less vague. So on this picture, I really don't know what it is, but I more tend this towards erysipelas. Colloquially, or most of the time in the hospital, you'll see they will call it cellulitis both times, because first it's really kind of hard to distinguish which one is which, but for you, like cellulitis is more less distinct, the border. Erysipelas is just very distinct. Okay, but the infection is the same, the treatment is the same. It's really the same type of condition. It's just higher laying, and it causes better border to see. Okay, so cellulitis will be deeper, dermis and subcu. Most of the time, legs, and it's basically red plaque. You will see, and sometimes even with like advanced cases, you can see that distinct border, but they will still diagnose it as cellulitis because it's just more colloquially accepted. But the correct way, if you see very distinct border, it's erysipelas, and cellulitis will be like vague. And this is probably, again, erysipelas and not cellulitis because the border is very distinct. So another one example here, what you guys see on this picture, Yeah, that's why I put it there. You see, and this is very common thing to do. This is done with ballpoint pen, maybe with thin permanent marker, which is probably better idea. So the you mark where the original border is, and here you see here it's expanded, but here it's kind of gone away, and maybe I don't know what, or maybe this is something else, but and the whole thing really stayed the same, or maybe this is a shadow. But my point is, why did I bring this? So you can see the marking. Okay. Why we're marking? To see what? Is it expanding or shrinking? Does our treatment work or not? How it behaves, basically. Because eyeballing really, or even measuring it, really doesn't have no value in a lesion like this, because if it was perfectly round, yes, you can say 10 centimeter diameter, and then you put 9.5, and then it will be shrinking. But something this complex line, you better be marking it and looking. You can take the pictures. More and more people will be taking pictures. Again, what's the problem with the picture for everyone? Back to generalized nursing issues. Can you just go to the hospital and start snapping pictures on everyone? No. Violation of privacy laws, and now it's HIPAA, who knows what it will be, but later, but it's like violation of privacy law. So it's all should be in this type of thing. If you're taking picture of the patient and you don't know who it is, right? It's just the leg, but you still have to have a consent to take a picture. You have to justify it somehow, that why you're taking a picture, for research, for study, for education. So you just can't go and snap pictures and saying, oh, I'll show it to my student. All will be neat. No, there were many times I wanted to, but I never done it. Maybe I should have. No, don't do that. It really will be taking pictures will be really will create very bad consequences in school or in career when you work. And many people fell into that trap, and many will, because people like to share things, and but this doesn't belong to us. It's the patient's leg. So seriously, so you have to at least consent your patient, and you have to justify it, and you can't just consent yourself. You have to go through appropriate bodies in the hospital anyway. But again, this picture is showing you the demarcations and marking on the skin. Okay. And another picture, erysipelas, and you can see the marking is more even distinct, and this is on the face. So what's the problem with this, guys, diagnostically? What you would say? Oh, honey, don't worry, it's just your rosacea kicked in. I don't have rosacea, never had it. Well, maybe you just developed it. It's just very tricky if someone, it's just red. I was, let's say, example, and it's a real example, like one of my friends, like, I was riding the bike and I fell into something. I think it's poison ivy. And it looks like this on the elbow. There's a nice line. And so, no, this is not a poison ivy. It really doesn't itch. That's one of the things you see with bacterial infection versus hypersensitivity reaction. It won't be really itchy. It's warm to touch, yeah, but it won't be really worrisome in the beginning if it's a small spot. But your key is that it's something, because what we think when it's infection, guys, what you think, what you expect to see if it's infection. pus, right? Vesicles filled with or whatever abscess. But this is like kind of yeah, like it's maybe some allergic reaction. No, it's not allergic reaction. So you're looking for the border, distinct border, and urticaria is that multiple appearance, the patchy, to differentiate from this to urticaria. This is always a some kind of closed circle or oval or space like this. There is no white spot. Urticaria is collection of plaques. So that's, if you see a border on someone's skin, it's something to be worried about. So anyway, so that's about cellulitis. You'll hear the word cellulitis much more than anything else. The treatment is, of course, antibiotics. If it's an advanced case, it's IV antibiotics will be. If it's something small, like that friend of mine, just going to urgent care and getting something like Bactrim, dealt with it quite nicely. But anyway, but it has to be treated. And the last thing, I don't want to go back because it will erase my voice, but last thing about cellulitis, why it happens. As any infection, there is a what? What? Breaking a barrier, yeah, good. And or portal of entry. It's not like something just laid there and start, like fungal infection started multiplying. No, there is a break, some kind of break in a barrier or portal of entry. It's not just like you touched it and it's there. There is something like got in. So something, and you may never see the portal of entry. That's why it's so concerning, because you don't know where it came from most of the times, but it's really very microscopic break. Okay. So anyway, warts or verruca, benign things. It's not cancer. Papillomavirus, we talked about it. Herpes simplex, I don't want to go. And herpes zoster and shingles is another name for it, right? Colloquial. What's the other disease? Chickenpox. So young kids will have chickenpox with herpes zoster. Elderly will develop shingles. So it's same virus, herpes zoster, and it's basically reactivation of herpes zoster in an elderly person. So not elderly person, you actually can be very young and but have it in your teens or even 20s. But yes. I don't know. I heard it. Chickenpox, you have to have a good immunity to it, and I can't explain it. Mono, you can have mononucleus. You can have rerun, because immunity fades. But chickenpox is usually one-time deal, and I never really heard about it, but everything possible. So, but usually reactivation will be as shingles, guys. So mono, if you go with the whole concept of immunity, why don't we immunize against mononucleosis? You can. But I mean, well, the same is chicken, yeah, but why don't you really immunize it? Because you really can't hold that long-term immunity for, like, you can get it, but chickenpox is usually, and vaccine effective, and you will, we actually require you at this point to get immunized, right? People who just got in, do you have to have chickenpox? No, you do, right? Yeah? But you had the disease. So you have to show proof of the disease or yeah. So, so anyway, um, so let's talk shingles again. Again, I flip to the next slide. Shingles will live where? Along what? Nerve pathway. So that's where it lives. And along what you call the nerve markings on the skin, what you would name them? Dermatomes. So along the dermatomes, rash will be located along the dermatomes. What else will be with shingles, guys? Well, what else will have patient will have? If it's along the nerves or it lives in the nerves, it's painful. So painful rash along the dermatome is most likely shingles. Do you have to send it to the lab to treat? Most likely not. And you have to start antivirals quite soon. But so, I'm sorry. What? Yeah. So like with any viral, most of the viral infections, not any viral infection, but most of the viral infection, the treatment should be started soon enough to to take care of the infection. If you start it late, it won't be effective. Most antiviral meds. Yes, kid. Yeah. I don't think so. If it's leaks at that time, maybe. But if it's like a crusty leaking infection, crusty leaky lesion, you can, but most of the time it's already so you have to keep children away from like someone with actively like lesions, you know, just happened, new shingles onset, yeah. contact things, yeah. So you take it from the exploded lesion, basically. Yeah, yeah, yeah. And sometimes they, like we had the Scottish students, and they said we don't have immunization. We have chickenpox party. If someone's kid have the chickenpox, they bring other kids and immunize them. Okay. Yeah, and so anyway, what were you saying? Well, it's reactivation. So immunocompromised. Yeah, but again, you guys, I know you guys all showing yourself your chickenpox scars. Very nice. So, that's, yeah. But shingles is again can be immunodeficiency, cancer treatment, immunodeficiency, some immunocompromise of some kind. And what else? Stress causes immune compromise. And in younger people, it's like severe stress can cause shingles or be a precursor. I really can't say cause shingles because what viruses cause. Yes. They might get it, so I won't be exposing any. Yeah, but I mean it's so. But you guys, it's really not a good thing to expose someone to that. But it's very short period. If the lesion is active, it's usually a very short time and you have to treat it. And sometimes it's not even painful, What's the other thing about shingles? Last thing before we move on. It goes on dermatomes. It's painful. It's reactivation. It's older, and the immunocompromised or some kind of stress. And what else? It's only on one side of the body. It can be on two sides, but it will never cross the midline on the back or on the front because your nerves don't, your dermatomes never connect really, truly. So that's how you look at it. So anyway, which one causes warts? And I didn't even make clickers because just everyone says B. Yeah, good. Any of them? No, not any of them. So okay, let me start. So we'll talk about acne. Main thing, like take-home message, right? I like to abuse those words. Take-home message is it's not a dirty disease. I mean, it's not something related to hygiene. It's hormonal imbalance. And to be more precise, it's like testosterone-estrogen imbalance in men and women. So sebaceous glands, they are getting stimulated by testosterone, and they can overproduce sebum, and it can get clogged, and the bacteria will get in and multiply, inflammation, and cause all the acne. This is not the acne bacteria. Propionibacterium acne is not a regular like skin flora, like strep. Sorry, I'll take it back. It lives on the skin, so it can be regular skin flora, but it can, if it's not getting into a sebaceous gland, you really don't see any problem from it. But when it gets in, you can see the consequences as inflammation, and you will have what kind of lesion with acne, you guys? What, vesicle or pustule? And I would call it not just vesicle but pustule because it's filled with pus. So again, but take-home message, it's not really hygiene or someone working like, he works in McDonald's in the kitchen, so he's exposed to heat and lots of grease and whatever, it causes acne on the face. No, it's a hormonal problem in the origin. So do you treat it with hormones? No. But you treat it with antibiotics, and you also can treat it with different substances, such as, and this is like I put it on the slide, not acuity but complexity of the treatment, and it's benzoyl peroxide. What's that? Benzoyl peroxide. It's benzoyl peroxide is a over-the-counter medication, or the one that Jessica Simpson sells, pretty much the same origin. I forgot what it is, but Proactive. Yeah, Proactive is benzoyl peroxide. There is also salicylic acid, which is also over-the-counter, and they work in mild cases. But retinoid are vitamin A derivatives, and hint, eating lots of carrots may help or may not with good skin, but overdosing on vitamin A, on the other hand, it's not good. But vitamin A is necessity for the skin. But retinoids will help to cut down the sebum production. Antibiotics, and it's usually doxycycline, and they really do miracles sometimes. So usually, and this is not like way to always do in your practice, but if it's reasonable and acceptable. Like if I see someone, let's say with ear infection, with acne, comes to the clinic, I'll try doxycycline, treating their ear infection. And ear infection in adult, we can't just do it like on the child, say wait and see it will resolve. In adult, you have to treat it. But I'll try it with doxycycline if it's reasonable, if it's, you know, accepted method of treatment, I'll do it and see if it works on their acne. But again, treating acne, it's kind of dermatologist domain, at least that first time. So if it works, we'll send them to dermatologist, say, you know, patient had doxycycline for ear infection, otitis media, and its acne got better, so maybe they will say, okay, well, let us start and monitor like long term, because it will be long term. So I won't be doing it in primary care. Accutane is, what, anyone heard about this? Yes. Huh? Yeah, well, what did you talk about microbiology? It's dangerous for what? For babies, for, well, not babies, but embryos. Accutane, actually, you have to sign like 500 forms and be in a registry to have the treatment. So it's kind of like extreme, but it works. And again, like your primary care physician shouldn't, or whoever, nurse practitioner, PA, shouldn't touch really Accutane prescribing you, at least initially, or is something dermatologists have to manage because of all the complication. And yes, Katie? Yes. Well, it's hormone imbalance. Actually, steroids can clear the acne because it's Oh, like anabolic steroids? You mean like testosterone steroids? Like, uh, I don't know. It can be like overproduction of the sebum, and I don't know what kind of steroids, but usually, like prednisone will actually calm it down, and they call it Prompac. Again, like dermatologists can do it if they want. I would never do it, but they will give like high dose of prednisone to someone who wants instant, fairly instant relief of acne, and they can go to their prom and be acne free. But you know, again, it's a treatable condition, and you know, sometimes you see people with acne and in the clinic, and you should at least refer and so. And it's a, I know you guys thinking it's not a big deal in nursing, but it's a big deal. And for especially teenage population, they think it's the end of the world. You're having acne. Oh my God, what am I gonna do? So I just, you know, that's impossible. I don't care if everyone else in my class has it, but mine is the worst. Definitely, mine is the worst, and I don't know what to do. So it's lots of problems, like what they call like body image disturbance. When you talk about nursing diagnosis, it can really functionally impairing, having like this tiny little problem. So it's good to treat and good to know, and you know. So anyway, but this is like the steps of treatment, and I won't be quizzing you on this in the test, but for you to know, I guess the take-home message again, most of the time acne should be treated or initiated with dermatology. So, psoriasis, so it's papulous squamous dermatosis, and you know, the rosacea, psoriasis, and lichen planus, they all, like we were talking about lichenification, and it's a exaggeration of normal skin marking. So for you guys, I want you to concentrate on psoriasis out of these three diagnoses, and but they are papulous squamous dermatosis. You know, so there are papula squamous, so squamous cells affected, and there are papules supposedly, which we don't see, as papules are small. But what we see here, you guys, what is it? Plaque. What kind of plaque? It's scaly. So it's scaly plaque. But yeah, plaque is a papule. So it's squamous cells, papules. But you see and if it's tiny, I guess it's papule then, definitely. But most of the time you see quite a plaque. Okay, so dermatosis, inflammation of the skin. Again, rapid turnover of the skin cells, autoimmune character. So, and that's mainly thing. Again, very specialty treatment, many immunosuppressive medications available. Interesting fact, some people with psoriasis, when they get chemotherapy and cancer treatment, their psoriasis will completely clear. Why? You guys, what you're saying? Yes, and that's exactly the cause, because your chemotherapy will target the rapid dividing cells, which is same psoriasis. But chemotherapy stopped, it will come back. So you can't just prescribe chemotherapy for just psoriasis, so it will be not really a good thing. But it's like the fact that it may happen. For the same reason, people will lose hair because will have problem with GI, like nausea, vomiting. With cancer treatment, and I know we're jumping back. Why? Again, hair, rapidly dividing cells, GI tract, rapidly dividing cells, so they all being targeted. And so our chemotherapy at this point is not selective, although there is many in work, and there are some already in practice, but most of the time it's non-selective treatment directed to rapidly dividing cells, which is psoriasis as well. There's really not much concern. The infection can be, but it's really cosmetic, and but again, like cosmetic, the old school is like, oh well, it's a skin layer, who cares? Like, so, but it's really can be debilitating. It can spread a lot. So yeah, it's important, because if someone like doesn't feel like going out of the house because of psoriasis, we have a problem. It can lead to depression, but like medically, probably, it's self-containing disease. The treatment can be actually more risk than disease itself, right? Because it's some kind of suppressive. So, but again, for you to know, it's rapidly dividing cells. Papula squamous is the key word. So if papula squamous dermatosis, you're thinking, okay, if it's papule, it's plaque, dermatosis, inflammation of the skin, and you remember that I was saying that it's a scaly plaque. And this doesn't look really like fungal infection. Why, guys? The last thing about this, it will have some degree of what? Erythema, the redness. Okay. The fungal infections usually don't look barely inflamed. They are really not. Okay. So psoriasis is like another slide just to give you an idea of what's happening. It's T cells will go in the epidermis. T cells getting activated, that's the main problem. And they will attract neutrophils in monocytes, and at the same time growth factors will attack keratinocytes, and that will create the papules or plaques. And on the other hand, this is what I was talking about. Your fungal infection doesn't have this inflammatory component but because of neutrophils and monocytes in the papules, the inflammation will be created. So this comes hyperkeratosis, another word, right? It's the scaliness and inflammation as erythema. So that creates that appearance. But again, this is like FYI slide. Basically, two components coming from T cells, neutrophils and monocytes, causing the inflammation, growth factor, telling the cells to rapidly divide. So, and that's what causes it. So, again, your immunity tightly related to T cells, as we know, and if you suppress these guys, this will be under control. So, sun exposure creates risk for cancers, and skin damage increases risk for these three cancers, right? So, basal cells, squamous cells, and malignant melanoma. The easiest to treat is basal cell. Squamous, the one with the worst consequences is malignant melanoma. At the same time, basal cell is self-contained cancer, and the chances of getting systemic or metastasized are very low. Squamous cell is somewhere in between, and that's what I want you to take from this slide, from this lecture. Malignant melanoma needs to come off immediately as soon as it's found, and while basal cell can be treated by even special ointments. Yeah. No. Yeah, it's not. I don't think so. The only genetic part is your skin type. You are more fair skin, and or genetic part, you lived in the same area and you get sun exposure, but it's really not genetic. And there are some insurance plans. You guys heard about insurance plans screening the patients over like pre-existing conditions, family history, but they would say it's like more humane approach, like, do you have family history of cancers, excluding lung cancer and skin cancer? Lung cancer because it's smoking, and skin cancer because it's sun. So it's not really, you can't, you really can't penalize anyone based on any family history, but there is no evidence that skin cancer and lung cancer are heredity, so you can't increase their premium because of that. So there is not really heredity component. In this too. Okay, so sun exposure creates ultraviolet radiation, of course. Sun creates ultraviolet radiation, which causes the damage. And how it starts, it goes to melanocytes. Tanning is a response to reduce ultraviolet radiation. So melanin is oxidized, skin gets darker, lets less light go in, and more melanin, it's just, again, does the same thing. Okay. When ultraviolet lights go into deeper tissues, they cause damage by A, DNA damage, and B, inflammation, which is basically sunburn. Okay. And also there is some immune cells damage. But your main concern with cancer is the skin damage through DNA damage. Okay. So melanocytes, what you want to know about malignant melanoma. Okay, the most dangerous skin cancer, right? Comes from melanocytes. That's what you're looking for. What did I put in here, guys? What it reminds you? Okay, I'll stand here. Oh, no, I'll stand to A, B, C, D. Cool. So you're looking for A, B, C, Ds for not just cancer, but any skin lesion, and typos on the slides too. So it's asymmetry. It's not round. Yeah, I made a nice typo here, but it's asymmetric, right? It's not round. It's not circumferential, really, lesion. It's like something like an ink spot. Border is irregular. Again, the same thing. So it's not just smooth line. It's going up and down. Color, not color variation. I meant. I don't know what variegation means. So color can be the same mole can be very pale on one side and extremely dark on the other. Okay, and the diameter is D, and it's getting bigger. It's more than ½ centimeter, and it grows. That's the other thing for diameter. And you can also put grows under evolving change of over the time. It's getting bigger. It rapidly grows. So that's your concern. B also can stand, I didn't put here, bleeding. So it bleeds with no apparent cause. Right? You are not really having any injury. I mean, any place you injure, I mean, a stab or puncture will bleed. But this mole bleeds by itself. Why? You guys who can answer this question, you can deduct this. Why the cancerous mole bleeds by itself? What's the word? Angiogenesis. Yeah, that's why it bleeds. It develops new vessels to feed it. So it's typical cancer. It's on the surface of the skin, but it's cancer. So it developed this. So you need to see ASAP. If you see on someone this, send them to a dermatologist, whoever. And I would send to dermatologist because primary care dogs, some of them can cut basal cell carcinoma, but it's really, but in malignant melanoma, it's really, I mean, any cancerous skin lesion has to go to a specialist at this point because we have specialists, we have the equipment and everything. So, but these are the things to look, guys. And some people would say, oh well, the moles have to grow and change, and sometimes they bleed, not a big deal. So your patient have no obligation to know all this. So you have to educate them, and most people more or less know this from TV, internet, and everything else. But okay, again, ABCs. These are two melanomas here. And I know you guys getting tired and sleepy, but we'll be done in a minute. See the color changes. Red and black at the same time is atypical. There's some inflammation here already going on, but there is it's not really symmetric. It's irregular. The borders are irregular. So I would definitely refer this patient ASAP to someone who can deal with it, to a specialist who can deal with it. I had someone ask before that, is it the same lesion? No. And you want to show the evolution? No. This is not the same lesion. This is two different lesions, and the reason is it's not the same because this has to come out. You can't just wait and watch. Okay, so both of them are malignant melanomas. Okay. Yeah, it has to be taken out, and hopefully there is no metastasis, nothing else is going on. So, yes. What? Elevation, yeah, that's good. Yeah, and E is elevation. Yeah, also, it's a raised mole. So you can come up with several other, but E, I heard E as well. So, good point. So E also can stand for elevation or evolving, changing. So C is change and color, but but that ABCD, main thing is what is really two things are important. to show it's cancer. You guys, it's asymmetry and color and bleeding, ABC. So, but you can really like come up with other things to describe. So, even one, if it's asymmetric mole, it has to be looked at. I mean, and it's probably something not good because you know, like regular moles are symmetric. If it's two colors in one mole, yeah, it's bad. So bleeding in out of. So yeah, that's a good question Sharon has. How many of these factors you have to follow? Even one of them, like rapid growth, even symmetric, it has to be checked. So they all, each one can be a risk factor. So this is like epidemiology, basically, data. Again, like you know already, probably in this course, I don't test you on numbers, but you know, these are just FYI information. Okay. So out of this slide, I want to bring you this curious fact here. The nail beds even can have melanoma. So the dot under the nail, I know some people would hit it with the hammer and have a what, hematoma? Yeah, and like it looks like round black dot and it will go away. But if the black dot under the nail doesn't go away and grows, probably it needs to be looked at. Okay. They even can be on mucous membranes. So basal is the least least dangerous. There is an indentation, or what I was calling this, who remember today, umbilicated lesion. There is a shallow lesion. It's a crater, or it can be really like a round circle with borders. So that's basal. And some of them, this is very like nice picture, but this kind of you know, more shallow, less border. This is like no inflammation. So they look different, and this is not good at all because it looks like it's spreading. So large amounts of sunlight, again, biopsy used for diagnosing everything, and you will eliminate the lesion. You can cut it out, or you can put a cream, and it's called Aldura. It's nobody knows how it works. It's antiviral as well, but it stops basal cell from growing. And if it's somewhere on the face and small lesion, probably cream is a good option to try. Another squamous, and it's invasive, and it will go to dermis and lymph node, and you know, again, has a shallow border and ulcer bleeding, but again can be very devastating. Difference between basal and squamous. Basal usually don't bleed, squamous will bleed. That's the difference, and it's like looks more, looks worse. So which one is the worst prognosis, you guys? Malignant melanoma, right? So it's really hopeful. I mean, anything open and bleeding will be more risk for infection, but hopefully by that time you've seen someone who takes care of it. Especially, yeah, it's a good point. But anything open bleeding will get infected on the skin. Again, repetition of the previous slide. You're looking for asymmetry, borders, colors, big size. Basal, survival rate is great, and squamous, you can detect it early and take it out. If it's not metastasized, it's really good prognosis. And basal is really slow growing. Last two terms, it's actinic keratosis and SK, and that's what I was talking about. The relatives exposure for like actinic keratosis, AK. So liver spot or lentigynes, and you can call them liver spots. They are some sun damage. Both of them is AK. Okay. So vascular lesions, angiomas, telangiectasias, and venous lakes, same things. Okay. AK, actinic keratosis, and it's a premalignant lesion. That's what I'm talking about. SK is on the next slide. Seborrheic keratosis. This looks bad, but it's not cancer. Okay. This is SK. AK is bad. To help you remember this, I'll say this. AK-47 kills, so AK is actinic keratosis, kills. SK is fine, but it looks bad. Why this is not a cancer, guys? Let's look at, is it symmetric? Yes. Is it fairly even color? Yes. Does it bleed? No. So, does it grow fast? Not really fast, but they can grow. Okay. And they are dark, uniform black or dark brown. So, AK is different appearance and lighter appearance and asymmetric. No, liver spots aren't. It was just on the same. Yeah, liver spots are benign, like pigmentation, basically damage. Okay. Xanthelasma is the basically cholesterol or fat deposit. It's really cholesterol deposit over the leads. I had the patient this Monday. She came to me. Sometimes someone would come and say, "I'm all for natural remedies," and I weighed, not making fun of it, but she weighs 298. She's not 300, but she's 298, and she's about 5'7", so she's a little overweight, but she's for natural remedies. She refuses to do the labs, and she refuses to take any medication. Her blood pressure is high, but she says it's just high because there is a blood pressure machine on it. So she's very adamant about treatment. However, she had this, and this is like a good sign to convince someone to do something about their health. I said, you have these xanthelasmas, and it may really represent high cholesterol. She's like, well, yeah, I read about it. Is it true? I said, yes, it's true. So, and she agreed to do labs. It was a miracle. I don't know why, but I talked about this. But they are benign, just cosmetic. But it shows that high cholesterol, and you can take them out, and it's like that. It's really becoming unnoticeable, and this will go away too. But the clinical significance of this is cholesterol deposits. Huh? It's permanent if you don't take it out. It will sit there. That's a surgical. That's like 1, 2, 3, before and after. So, yeah, but it's fairly. I don't know if it will go away because it really doesn't have a blood supply, and it just sits there. So the only way to get rid of it is surgical. So we talked about AK and SK. The AK's main thing is here, if you want to highlight it, that risk for progression to squamous cell carcinoma. Okay? And that's I can't say this word, I practice some imiquimod cream, which is Aldera. They call it Aldera. I can say that, but imiquimod, and imiquimod. It's a miracle drug. It can take, again, antiviral. You can treat warts with it, but it's very expensive to treat warts. But for basal cell carcinoma, it can work fine. And AK, actinic keratosis, and it looks like not kinda, it looks like this. So black is good, white here is not, white yellow isn't good. The black round lesions are okay, even they look very bad, but AK isn't okay. SK is benign